Good morning, everyone. My name is Christopher Roy, and I'll be talking about the COVID-19 pandemic and its relation to hospital medicine. I'm the Director of Hospital Medicine at Brigham and Women's Hospital. I have no disclosures. So objectives today, I would like to perform sort of a post-mortem of our COVID-19 response at the Brigham, look at what we did and what went well, and lessons learned for the next surge. I was the inpatient operations director for the incident command at the Brigham. So I can speak to what went well, the challenges, and what we can do next time. I want to use the second half of the talk to talk about key clinical topics related to COVID and non-ICU patients, patients who are admitted to the floor. This is no news to anyone here unless you've been on another planet. We've had a global pandemic since December of 2019 that started in Wuhan, China. The virus causing the pandemic was named SARS-CoV-2 and later named COVID-19, the disease that it causes, by the World Health Organization. There was rapid spread globally, of course, and hospitals here in the US were caught by surprise, prepared the best they could with limited time, but testing was not adequate in the initial weeks and months of the pandemic, and we also suffered some pretty serious shortages of equipment. In terms of what happened at the Brigham, let me give you a little background about our hospital. Brigham Health includes two hospitals, a nearly 800-bed academic center here in Boston, and a 162-bed community hospital, Brigham and Women's Faulkner Hospital, which is about 2.5 miles away from here in Jamaica Plain. And in early February, an incident command was assembled, seeing what was going on across the globe, and it was separated into planning and operations. We had representation from every clinical area. As I mentioned earlier, I was in charge of the inpatient service, but we had representation from the ED, the ICU, other areas. And this was all organized under the incident command for the entire health system, which is now known as Mass General Brigham, formerly known as Partners Healthcare. By early March, we had shut down most elective admissions. The surgeries, et cetera, had stopped. Our census dropped pretty abruptly to 50% of our baseline census, which normally runs in the 95 to 105% range. What was unusual about this to me was that even the general medicine service, which I'm quite familiar, dropped by half as well. And we think, of course, that this was due to the fact that many patients stayed at home and did not come to the hospital for fear of getting COVID themselves. We also implemented, as everyone else implemented, a no visitor policy. This was a pretty strict no visitor policy. It was only, the only exceptions were at end of life and at birth for one visitor. And as a result, the hospital looked pretty much like a ghost town. Walking the halls here at the Brigham, I've been here 25 years, and it was very spooky to see the lack of people in the hallways, the lack of people in the wards, no one in the cafeteria, et cetera. And I'm sure that this is a familiar story to many of you. We had to prepare, and part of our preparations were to look at the beds we had and what we would need to do to expand for the surge. And this was guided by data that was being collected across our state as well as by our own health system. But we were charged with essentially tripling our ICU capacity and increasing our non-ICU capacity for COVID patients by 1.5-fold. The one unknown really was that non-COVID census that we had seen fall to 40 or 50%. Would those patients come back in the middle of the surge? Would people not stay home with their myocardial infarction or pneumonia, and would they be coming to the emergency room? So in the calculations, we just factored in that it would stay at that level, not knowing what would happen. So all told, we were increasing our hospital capacity quite a large amount. We had to use sort of non-traditional areas to map it out, the post-anesthesia care units, the operating room, other recovery areas. And even when we did all this, we had a deficit of about 32 beds. And we decided that if we would exceed the head walls in this in our hospital, meaning the where the oxygen and monitoring capacity comes in for each bed, we would start using common areas without head walls, conference rooms, waiting areas, that kind of thing. In the emergency department, they erected 2 tents outside for testing, for increased capacity for PUIs, persons under investigation. And our goal was to cohort patients as best we could, patients who were at risk for COVID or were COVID positive in wards and ICUs that were geographically localized with negative airflow. And the one thing that we had an advantage among many hospitals is that we had a lot of negative airflow beds. We have one tower that can be entirely negative airflow. So we knew we would be using that. That was 134 beds. In terms of staffing for the surge, it was pretty clear that we were not going to have enough staff for this many beds. As such, we had to conscript many attendings, fellows, residents, APPs, and others, and to work on these services. And there was this labor pool effort that was implemented by the hospital to help recruit staff from other areas, surgery and other areas that weren't busy because the census had dropped. And the goal was to match skill sets with the needs that we had. We expected about a 20% attrition rate due to healthcare worker illness. This is what had been seen in Italy and China. But in fact, this was not realized, and I'll talk about that later. Fortunately for us, we did not have that degree of illness among our staff. We had about 10%, though, that needed accommodations due to their personal risk factors, physicians or nurses, et cetera, who were immunosuppressed, were pregnant, advanced age. Those are the big ones. And as such, we set up a virtual rounding system to utilize people that had accommodations and also others that were working from home. This virtual rounding system was set up in Microsoft Teams and allowed the off-site clinicians to do work in the computer in Epic, our electronic medical record, so that they could assist the teams taking care of this volume of patients. The fortunate thing for our surge was that we did not get to this. Crisis standards of care, kind of a term that was coined to indicate that if we had resources that were extremely limited, we needed some kind of rubric for rationing care. Should we run out of ventilators, for example, we would need to ration. So this was set up. The crisis standard of care would be activated by the governor and by the city, and once we knew that we were clearly running out of resources. And we set up physician teams that were going to arbitrate using this algorithm who would get the care and who would not, based on their score on an algorithm that had been developed. These were not physicians that were on the treatment team. We felt strongly that it should not be the physicians caring for the patient that would make these calls. The scoring system took into account age and comorbidity and severity of illness. There were some controversies. Status as a healthcare worker was one controversy. And initially it was felt that this should not be used as sort of a tiebreaker, but later they capitulated. We capitulated on that, and we used status as a healthcare worker for equal patients, and given the situation, this would give them extra points. However, we were very fortunate that we didn't have to get to this stage. There were concerns about disparities in care and equity of care as well, given that the comorbid conditions that drove the score that was developed was higher in minority populations. And in fact, minority populations were the largest proportion of patients in our COVID surge, coming from poorer neighborhoods in the areas around Boston. We set up these special pathogens units, they were called. We called them special pathogens units and not COVID units because that way we wouldn't have to change the name should a different pathogen come in the future. We repurposed areas in the hospital, including the Center for Women and Newborns and the Cardiovascular Center. These were newer buildings that had built-in negative airflow, and so they could be switched on should they be needed. Hospital IS set up a video intercom system in each room, which was incredibly valuable and allowed us to communicate with patients through the door, essentially. The nursing staff and the physicians would be able to dial in and essentially have a video conference with each patient. And also the video could be left on so they could be a patient who needed to be monitored could be monitored from outside the room. This decreased our burn of PPE and also, of course, the risk of exposure to healthcare workers. We set up PPE trainings so people would know how to don and doff, but the biggest help in preventing breaches in PPE was a trained observer program that we set up with patient care assistants, 1 to 3 each 3 rooms, who would observe donning and doffing as providers exited and entered the rooms. We also needed to preserve PPE given shortages, and we set up centralized distribution of all PPE, so people had to report in the morning and use their ID to get PPE because it was disappearing on the floors. We had to reuse N95s for several days in a row, sometimes a week or more, given the shortages, which later eased up. Infectious disease and biothreats were our partners in this, and they were embedded in the teams. They rounded with us. And this was super important for us to keep ahead of the very complex and changing CDC requirements and guidance that was coming it seemed almost daily at one point. We set up lists for these teams in Epic with risk indicators indicating their testing status, their oxygen requirement and needs, and if that was escalating, and also biomarkers of risk, and that'll go into later on. This is how our surge looked in terms of the past 4 or so months. So we started with our first patient in early March, and by mid to end of April, we were at our peak, hitting in the mid 20s to 30 admissions of COVID positive patients per day. This was a very busy time. We were having several intubations, 5 or more intubations in the emergency department, as well as some on the floor. And then it eased up, and I think with social distancing measures that were put into place toward the end of March, we started to see the effect of that, and more discharges started occurring than admissions, and now we're at a handful of patients here at the end of June. So what were the challenges that we faced? So the first challenges, of course, were testing, and I think this was not unique to us. The testing was very, very limited, had a prolonged turnaround time. The CDC had their PCR that they had distributed to the states, and this had problems. Later on, we got in-house testing and we got commercial tests, all of which still had a prolonged turnaround time for some time, and were plagued by supply chain issues. There are other shortages of equipment, including swabs and thermometers, and we had concerns about our ventilator supply. There were rapidly changing recommendations from infection control, again, almost daily. The testing protocols changed, and we had a decreased ability for obtaining specialty consultation compared to what we were used to, because everyone was limiting their face-to-face contact with patients, and we had limited the number of providers entering the room. So this often resulted in delays in consultation. Probably more importantly was our ability to communicate with families, especially regarding goals of care. It was very difficult to do these discussions with families on the phone or on video. And there was extra barriers to communication with non-English speaking patients, of course. So what went well? Well, I've been at the Brigham, as I said, 25 years, and I've never seen such amazing collaboration and teamwork and volunteerism. People were innovative. They really made do with what they could in a time of extreme stress and lack of resources. We were able to stay ahead of our surge here in Boston. We opened more than 100 new ICU beds, and we had 14 new inpatient teams running within 4 weeks. Really amazing effort, and to assemble this, an amazing amount of work from everyone in the hospital, essentially. Our engineering department, fortunately, was able to keep us in negative airflow rooms for just about all of our COVID patients. They had the rooms that were set up for that I mentioned earlier, but also there were more rooms that they retrofitted for negative airflow. And because it was cooler outside, this didn't affect the HVAC in our hospital to the extent it would if it were like 90 degrees. So we were lucky that it was cooler. We had an amazing collaboration with palliative care and geriatrics that really helped us with those goals of care discussions with patients, and primary care as well, who would address goals of care with patients even prior to getting COVID in the outpatient setting. It was extremely helpful to have that help. And like I said, I think because Massachusetts implemented social distancing measures fairly early on, we were fairly lucky. We did not have the 20% attrition rate that others had seen. Only 2 of 90 of our hospitalists actually tested positive, and they were doing quite a lot of the non-ICU care. So I thought that was very good news for us. And our surge only peaked at about 170 patients, which was only about 20% of what we had prepared for. So we were over prepared, but that was a good thing. I think everyone felt comfortable with what was going on. And we were also fortunate to have remdesivir early on because of the trials going on at our hospital. This was unique to our hospital. The other academic centers did not have trials of remdesivir that were happening. So what happens next time? So of course we have several advantages. We have the testing in place now. We have all the workflows in place. We will have had the experience of going through this before. And I think we will have warnings in advance because we've set up systems to track ED visits and respiratory clinic visits, as well as percentage of positive tests and others. And the question, though, I think is, will we listen to this data when we get it? I think there's generalized fatigue from COVID right now, and everyone is eager to get back to business as usual. But of course, this could happen, very well could happen again. I just wanted to use the remainder of the talk here to talk about some clinical topics that I think are important for practicing hospitalists, those practicing in a non-ICU setting. And those are looking at risk factors for clinical deterioration, looking at awake proning, and the need for advanced oxygen support in these patients. I'll touch on post-ICU syndrome and delirium, and medical errors that are unique to the COVID pandemic, and finally, how to discharge a patient with COVID-19. So the high-risk indicators, many of you may be familiar with age, and male sex, as it turns out, is probably not as strong as an indicator as we initially thought. This, again, was due to the data coming out of China, but may have been more biased. Comorbidities, this list is growing. I only have some of the big ones here, but CDC recently added obesity to this list, among others. the symptoms and signs on presentation of dyspnea and tachypnea, as well as dizziness and anorexia, seem to indicate higher risk. So if your patients end up presenting in that way versus anosmia, which seems to be lower risk. Patients with certain labs are at higher risk, and these are some of the labs that we track in Epic in our dashboard, so we can take one look at a team of patients and see which patients are having changes in their labs that would indicate high risk. And that would be leukocytosis, lymphopenia, high LDH, D-dimer, CRP, ferritin, troponin, and procalcitonin. And IL-6 is another one, but we don't tend to get that because it takes a while to come back at our hospital. These indicate a very high inflammatory response, which seems to precede the respiratory failure, and is what we're trying to capture. This is our protocol for calling the ICU. I just wanted to call out one line here, and that's a need for O2 greater than 6 liters per minute nasal cannula. And that was our early criteria to call the ICU, but that changed over the course of the pandemic as we got more comfortable with these patients. And we actually started to recognize that maybe we were being too aggressive with patients with a relatively low oxygen requirement. And I'll talk a little bit more about that later. In terms of risk scores for deterioration, many of you who have EPIC in your hospitals may have seen this, the EPIC Deterioration Index, or EDI. We have it in our system as well, and it has been used in dashboards for COVID patients. And it's just to be aware of what it is, it's a proprietary risk score. It's generic. It doesn't, it's not specific to COVID in any way. And it's supposed to identify patients who are at risk for going to the ICU or doing worse. This was a study, these authors looked at 174 COVID patients, and they found really that this EDI didn't really work that well in terms of discrimination. It identified a small number of high-risk patients and a small number of low-risk patients, but the discrimination was only fair, and there was a relatively poor sensitivity. So there's a large swath of patients who are still intermediate risk and didn't really help with. So I would be careful. I take this one with a grain of salt. In addition, there was another review of prediction models that have been published in the literature since the pandemic started, and there were 66 prediction models that have been published. The authors of this review found that most of these prediction models were biased, of low quality, and had too optimistic performance by their authors. So they concluded that we should be very careful using these prediction models. I think there's been a rush to publish anything COVID in the literature, and we should be very careful about making clinical decisions based on these. Let's talk a little bit about controversies in hypoxemic respiratory failure. As I mentioned earlier, because of reports out of China, we were suggesting that we should be intubating patients who are on relatively low levels of oxygen and desaturating. And that's how we managed things early on, because that's all we knew. But as I said earlier, got a little bit more comfortable with the disease and found that patients could tolerate higher levels of oxygen and not get intubated, we actually kind of pulled back from that. And now we use these criteria: oximizer at 12 liters and venturi mask at 60%, with increased work of breathing or desaturation. Early on, also, it was discouraged to use non-invasive positive pressure ventilation as well as high-flow nasal cannula. And high-flow nasal cannula was avoided because of concern of exposure. But now we're reconsidering that as well, and I'm going to talk about that in a little bit. But first, I wanted to mention awake proning. awake proning has a long history in ARDS, in intubated ARDS patients. There was a landmark study in 2013 in the New England Journal that looked at the benefit of awake proning in these patients. And the physiology here is, of course, is to recruit alveoli in the posterior lung zones that are relatively under recruited when you're lying supine, and to shift the perfusion to the healthier alveoli in the anterior lungs, and to thus improve the VQ mismatch, and also maybe increase secretion management. Prior to COVID, though, for awake proning, meaning for non-intubated patients who are not on a ventilator, there were very few studies, but there was this one that was a small retrospective study looking at proning in only 15 patients with respiratory failure that weren't intubated, and it did in fact increase the PaO2 to FiO2 ratio, the PF ratio, by 16, and didn't affect the pH or the CO2. So there were a few other studies like this that suggested maybe we should be doing this in COVID patients who are not intubated on the floor. And this one was published in JAMA a few months ago now. And it was, again, a small observational study looking at only 24 patients. More than half of them were able to lie prone for more than 3 hours a day. And unfortunately, the PaO2 only increased in 6 of these patients. And only 3 of them had a sustained response. Here in the orange, the ones in orange were the persistent responders with a persistent elevation in PaO2. I'm not to say that this is not effective. Anecdotally, we did see patients who were much more comfortable lying in the prone position and actually did it voluntarily and found that they were able to breathe better. I think what is needed here is some good randomized trials, which are underway currently. So going back to high flow nasal cannula, is it unsafe? Well, the theory is that SARS-CoV-2 is viable in aerosols. It stays viable in non-porous surfaces for many days. High flow nasal cannula is made of plastic. Could it be staying on there? Could it be re-aerosolized, et cetera? So the risk of healthcare worker transmission is not insignificant, but there have been several studies looking at how unsafe it is. This one by Leung looked at high flow nasal cannula versus 6 liters of face mask and found no difference in the spread of bacteria in a patient's room who were on high flow versus regular face mask. That was bacteria, not viruses, but kind of some evidence there. And there have been some other experimental studies to that effect as well. So given this, and given the potential benefit to patients, we have a protocol now for using high flow nasal cannula in COVID patients, and with some precautions. We do put them in negative airflow. We use the full strict isolation precautions, including N95 and face shield when we're doing this. But this is our protocol, and we believe that high flow can be used in selected patients who could benefit and perhaps avert intubation. The post ICU syndrome, PICS, and is a prominent part of COVID. For those of you who are unaware of PICS, it's 3 domains. One is cognitive, mood, and physical impairment. Patients coming out of the ICU are very debilitated, and it depends on how long they've been in the ICU, how long they've been sedated and on ventilation, among others. And we should not forget that families can also have significant post-intensive care syndrome characterized by PTSD and others. Delirium is a big part of PICS and a big part of our COVID-19 patients that we saw. Almost all of the patients coming out of the ICU at our hospital were delirious to some degree. I think in the Chinese experience, this was a little bit an underestimate of how often patients were delirious as many as 70% of patients are probably delirious when they come out. It's not clear if this is due to COVID itself or if it's just critical illness encephalopathy that just is severe. There's high cytokines, there's invasion of the virus into the olfactory nerve, among others, that make you concerned that potentially COVID itself is causing some kind of encephalopathy. But there is a big factor here is that it persists. What we saw with our patient population was that they stayed delirious for a long, long time. And we had some patients staying in the hospital for 60 days or more and couldn't be placed because they still needed a sitter. They were still very agitated. And I think partially it's due to the fact that the risk factors for delirium don't go away once they get out of the ICU. They're still in isolation. There's still a very sensory deprivation kind of situation. There's concern about the disease that they have, and there's limited interaction with family, et cetera. Switch gears a little bit to talk about medical errors. I feel fortunate that we didn't see a ton of medical errors during our pandemic surge, but I think this is something that we did see a few of. Some categories of errors that you might see and during the pandemic were obviously delayed in diagnosis when testing wasn't adequate. We soon moved to testing all admissions to the hospital, so this became less of an issue. Even asymptomatic patients are now tested when they get admitted to the Brigham and to all partners hospitals. This could result in exposure to healthcare workers. There is concern about this idea that we would delay diagnosis of other illnesses and really focus, because we're focused so much on COVID. And we did see examples of that where patients were coming in actually with something else. There's the idea that patients are staying home and getting sicker before they come in, and that's the concept of sort of collateral damage. And then, of course, all the communication barriers that are set up by strict isolation precautions, as well as falls and other hospital-acquired errors that can occur. This is a table from Tejal Gandhi, who is a sort of nationally known expert in patient safety. Her sort of rubric for thinking about these errors during the COVID-19 pandemic was published in Journal of Hospital Medicine. You can take a look at that when you have a chance. Lastly, I want to talk about discharging patients with COVID-19. This was a time that was incredibly anxiety provoking for physicians and patients when we were actually discharging our first patients with this disease. The first concern, we had patients whose family members were physicians. They were concerned that they would have this resurgence of respiratory failure 8 days after their symptoms onset. And this could happen at home. There was also the concern from our standpoint, as well as from families, that the patient couldn't really quarantine safely, that they had elderly family at home or others with risk factors who needed to stay away from them, but they lived in a very tight situation in an apartment building or whatnot. And there were really limited post-acute beds during the pandemic. That was another major shortage for us. We set up a discharge checklist for COVID-19 that is here, broken down into several domains. What is important to set up prior to discharge, to make sure that they have the support that they need at home, they have food, they have their medications, we sent them out with their medications, they have any kind of medical devices that they need. They have transportation, they have good discharge instructions about how to quarantine, and they have a follow-up plan with their primary care physician, as well as a post-discharge telephone call, telemedicine visit. We set up, at Partners, they set up a home digital monitoring program for patients who are discharged home. which is an incredibly helpful to patients to reduce our anxiety and theirs about safety. They were sent home with an oximeter and a thermometer and a mobile app in which they could report their symptoms and their O2 saturations. And this was monitored 24/7 by a nurse physician team. And it was set up to be alerted in epics so that if a patient had a worrisome trend, the healthcare provider would be notified. Last slide on Boston Hope Medical Center. This was a 1,000-bed field hospital that we set up at that partners helped set up at the Boston Convention Center, funded with private and public dollars. It was staffed predominantly by Brigham and Mass General physicians, as well as others from around the state. And it was actually ready within 8 days of construction. This was an empty room, and after about 8 days, it looked like this, and they started taking patients there. So this was a place where we could send patients who needed skilled nursing, but also homeless patients who could not go back to the shelter because they were COVID positive. So just some take-home messages. We had initial challenges that were severe. It took massive efforts by many people to stay ahead of the surge that we had here in Boston. We feel lucky that we were able to stay ahead of it, and we hope next time we'll be equally ready and it will be a little bit easier. There are trends in labs and clinical parameters that can be helpful in predicted deterioration and need for ICU transfer, but we have to be careful about using some of these published prediction models. They might be unreliable. Await proning may be beneficial, but await randomized trials. We had a low threshold for intubation, but that has eased up. We also had a restrictive policy on high-flow nasal cannula, which is also easing up. The post-ICU syndrome and delirium are very prevalent and are a major problem for patients with COVID-19 and need to be addressed and studied more. We should be on the watch for medical errors, as we always are, but specifically those errors related to COVID-19. And finally, discharge can be hopefully made safer by using checklists and addressing all of the concerns that patients with COVID have, and also potentially implementing post-discharge monitoring programs. Thank you very much.